Good afternoon, everyone. Just waiting for people to jump in, and we'll get started in just a minute here. Okay, so thank you for being here today. We want to welcome you to this webinar. My name is Melissa, and I'm the Behavioral Health Consultant for the Overdose Prevention Engagement Network, or OPEN. We want to welcome you today to the webinar, Meeting People Where They Are, Enhancing Engagement in Opioid Use Disorder Care for Disadvantaged Populations. During our presentation today, audio and visual capabilities will be turned off for attendees to limit distractions. Please submit your questions using the Q&A function on the Zoom toolbar at the bottom of your screen. Click on Q&A click on Q&A, type your question, and hit send. We'll address these questions as time permits during the Q&A portion at the end of the presentation. We are offering CME, Social Work, CEU, and McBAP credits today. We'll have a slide up with the information about obtaining these credits during the Q&A portion of the webinar. We'll also be emailing the continuing education credit information after the webinar today. So the Overdose Prevention Engagement Network, or OPEN, is a diverse team dedicated to improving lives and reducing harms of substance use. By engaging with individuals, communities, and organizations, we share education and resources to strengthen person-centered prevention, treatment, and recovery. With an overarching goal of developing transformative, evidence-based solutions to reduce harm and stigma surrounding substance use, we work to support healthcare providers and communities in understanding and addressing substance use disorders at every level. We offer a variety of evidence-based services and resources. We offer on-call consultation services to connect prescribers to our addiction medicine experts who provide guidance for managing patients who have substance use disorder or complex pain, and who can answer both individual treatment and technical assistance questions. We offer expert-led education and training sessions, and many of our webinars offer free CME, CEU, and McBAP credits. And for prescribers, all of our credits also qualify for the DEA required substance use disorder training. We provide medication for opioid use disorder training for providers. And this year, we are incentivizing primary care providers and advanced practice practitioners with $250 to complete one of our MOUD trainings. We hope this encourages confidence and willingness to help expand access to MOUD treatment. To prevent new persistent opioid use, OPEN established and continues to update evidence-based opioid prescribing and counseling recommendations. These recommendations are based on patient-reported outcomes and offer various acute care episodes and provide data to inform opioid prescribing. OPEN also provides tangible tools to reduce harms of opioid and substance use, and our hope is to disseminate resources to places that need it most. We encourage you to partner with us and apply for our programs. We offer a free library of evidence-based printable educational materials for both patients and providers. Patient education materials can be co-branded for free and are available in English, Spanish, and Arabic. Provider education supports best practice implementation for primary care, acute care, obstetrics, pediatrics, and dentistry. We provide safe medication storage and disposal options. We assist groups all across the state in hosting local medication take-back events. We fund implementation of permanent medication disposal boxes for qualifying applicants, and we provide charcoal disposal bags and medication lock bottles for healthcare and community distribution. We offer overdose rescue support. We fund implementation of naloxone vending machine and distribution boxes. We also offer naloxone administration training, and these trainings are offered in person or virtual and are free. You can access more information about all of these services more directly using the QR codes or by visiting our website. OPEN understands that effectively addressing opioid use disorder and other substance use disorders requires deep collaboration and tailored solution to meet the unique needs of each part of the state. Our behavioral health consultants, or BHCs, work directly with physicians, physician groups, and community organizations in your area to help build connections and networks locally throughout the state of Michigan. So I'm happy to introduce our speaker for today. Dr. Eliza Hutchinson is board certified in family medicine and addiction medicine and currently is an assistant professor of family medicine at the University of Michigan and medical director of addiction services at Packard Health, a federally qualified health center in Ann Arbor, Michigan. She also provides education and support to clinicians across Michigan through work with Michigan Open. Prior to living in Ann Arbor, Dr. Hutchinson provided primary and addiction care at a federally qualified health center in Seattle, Washington, and served as clinical site director of a low-barrier, community-based model for substance use disorder care. Dr. Hutchinson is a passionate advocate for expanding primary care-based addiction treatment rooted in harm reduction, improving the health of individuals affected by incarceration, gender-affirming care, and stigma reduction. Thank you so much for being here today, Dr. Hutchinson, and I will now turn it over to you.
All right, thanks so much, Melissa. I am going to share slides and please let me know if you can see. Does that look great?
We can see the side slides. That looks good.
All right, good. Okay, fantastic. All right, well, thank you everybody for joining during probably what is lunch hour. So I hope everyone has food and caffeine. Excited to have you all here. I know our format is not highly encouraging of a lot of engagement, but please do put questions, thoughts into the chat. I guess actually we're using the Q&A function. So anyway, we are happy to answer those and then also can learn a lot from what you all share. So please do feel free to use that. We do not have any disclosures, and this just kind of goes over the availability to get CME credit and how to do that. But we do not have any financial relationships with any ineligible companies. I am just going to briefly go over our objectives, which today are going to be to, first of all, kind of just describe the disproportionately high rates of adverse effects of opioid use disorder among certain disadvantaged populations and some of the reasons for those disparities. And I am going to mostly just use the terminology OUD, and then you'll hear me use MOUD for medications for opioid use disorder. We'll talk a little bit about strategies that we can all employ in our various care delivery systems to hopefully better engage folks in care. And then my hope is really that you come away with like one actionable step that you can take in your own care setting to help address some of these inequities. So we'll first just kind of talk about, what is a problem? Why are we having this conversation? I think we all know by now that we do have really powerful life-saving treatment available for opioid use disorder, but a lot of people are, of course, still dying of overdose. And in particular, people with really highly stigmatized identities, which is where I'm going to focus today. And then we'll kind of move into some solutions that have been emerging and talk a little bit about some details of those. And then finally, just kind of going to reflect on some actionable steps. And again, my hope is really that, to present sort of a menu of options of things that you might adapt in your care setting. It's not sort of all or nothing, but if you can just find one or two things that you might be able to do differently in the constraints or the confines of your setting, I think that is a win for today. And then my other piece is just, I'm going to be talking about several specific populations, but obviously this is not an exhaustive list of folks who are highly affected by OUD, but just some of the really paramount ones that I think are important to discuss. And then very finally, before I go forward, is I am also a primary care provider. So for those of you who work in busy primary care settings, a lot of what I'm going to be talking about might feel like a tall order to squeeze into your primary care setting. So again, just encourage you to sort of focus on just one or two take homes that you can take in your care setting. So first of all, we all know this. We have probably seen this, heard it everywhere. Drug-involved mortality has been increasing in recent years. This gray line is just showing really the skyrocketing overdoses related to fentanyl and related analogs. So regardless of what we've been doing, there's still more to do. There was, as probably many people may have heard, I think this was an NPR story just last week, that actually just in the last couple of months, we have seen dramatic decreases in mortality across various states, anywhere from 10 to 30%, which is enormous and really exciting. I think at this point, nobody really understands why, even though there's excitement around the fact that it is happening. But I just sort of wanted to point out, one of the many theories is that obviously it's multifactorial why this is happening. But as Dr. Nora Volkow at NIDA says, that some people are definitely pointing to rapid improvements in the availability and affordability of medical treatments for fentanyl addiction, expansion of naloxone, and medications for opioid use disorder, and these strategies have worked. So regardless of all the reasons, probably the availability of these medications is a piece of it, and some of our evolving care models that we're going to be talking about today have contributed to this decrease, and hopefully we'll continue to see this happening. But let's talk a little bit about sort of specific populations that are highly affected. So first of all, again, I think something that is much more out there in the news and in regular conversation is, of course, the racial disparities that exist in opioid use disorder, in overdose, and actually in MOUD access. So we've seen, as you see here in the graph to the left, the overdose rate among Black men in the US more than tripled in the 5 years from 2015 to 2020. And in 2020, for the first time, overdose deaths in Black Americans surpassed that in white Americans. And then there are lots of theories, of course, behind this, and sort of beyond the scope of this talk, and sort of the history of racism in our country, obviously being the leading cause, manifesting in multiple ways. But specifically, there have been a couple studies also looking at availability and engagement with MOUD care. And we really do see, as you see here on the right in this pictorial, this was a study from 2023, showing that this is looking at folks who had an OUD-related event, so namely overdose or a significant hospitalization. And they looked at folks after that hospitalization or after that overdose event and followed up whether they received MOUD or not. And they found significantly lower rates of Black Americans getting MOUD treatment compared to white Americans. So where we're going to really be trying to dive in today is, how do we adapt our care models perhaps to better engage this population in our MOUD care? This is just showing similarly in Michigan. The top blue line is Black Michiganders, and we see that for quite some time, actually, overdose death rates has been higher in Black Michiganders than in white, but has sort of increased disproportionately over time compared to the other groups as well. Second group that I wanted to highlight, and certainly overlaps with the racial disparities, but we see tremendously high rates of substance use disorder in general, and overdose in people with any kind of justice involvement. So if you see kind of in the upper right pictorial here, diagnosable substance use disorders, we think about 9 or 10% of the general population has them. In state prisons, about 50% of people do, and then close to 70% of folks in jail have a diagnosable substance use disorder. And then importantly, related to that is fewer than 15% of those folks are actually receiving appropriate treatment. Over on the left, this is a study that's a bit outdated now, but really was sort of the seminal study helping us start to think about the high rates of death in folks who are releasing from incarceration, specifically the 2 weeks after release. And we know that deaths from all causes are about 12 times higher than anybody else in the population. But specifically, the risk of overdose death is tremendously higher. And this graph on the right is more recent data showing that folks in the first 2 weeks after release from incarceration are about 40 times more likely to die from an opioid overdose. So really, really important population for us to be working hard to engage, and may take some different strategies than other parts of the population. The third population, again overlapping, but that I wanted to address was folks living homeless or unhoused people. And this quote, I think, just sort of encapsulates what I think we all sort of know intuitively, but it's very difficult to maintain any kind of treatment if you're not housed. You're in an environment where there's lots of exposure to substance use, where people are using substances as a survival tool all around you. And at the same time, you have competing priorities for food, clothing, and shelter. I can't overstate how difficult that is. And I think this quote really reflects what we see in the numbers, which down here we see, this is data from Massachusetts, but 1 in 4 deaths among people who were unhoused in Massachusetts was due to an overdose. And actually drug overdose has been the #1 cause of death among unhoused folks in Philadelphia. So again, population with certain specific needs that we might think about addressing with various care models and clinical approaches. So, we have these problems, we have people who are still dying of overdose despite our encouraging trends. So we do have tools, of course, and I think anybody who has probably attended any open webinar or paid attention to anything in the news knows that we have, very, very powerful tools, specifically medications for opioid use disorder. And where I'm going to mostly be focusing today is buprenorphine, since that is sort of the tool most available to all of us in our care settings. And buprenorphine shows really a 50 to 80% decreased mortality, depending on the study you look at. So profoundly powerful tool that we have. And despite that, fewer than 20 people are actually receiving opioid use disorder specific treatment. And if you look at this image on the right, this is a study done at a syringe service program in Washington in 2017, sort of, asking people, did they want help with their opioid use? And then if so, what's the kind of help that they wanted? And, not surprisingly, 70% of people wanted opioid use disorder medications, and that was the top type of help that they wanted. So just sort of, people who are using drugs completely understand the effectiveness that we see in the literature. So our challenge is really, we have this amazing tool. How do we get it into the hands of more folks who need it? Again, probably many things that you all see, and those of you who are social workers here are probably dealing with all of these the most out of any of us. But there are so many challenges that people face in accessing, medical care in general, but speaking specifically about medications for opioid use disorder. And this is everything from sort of people's own experiences that they bring with them, other illnesses that they have, housing instability, transportation barriers. They don't have an identification. They don't trust the medical system. So many things going on in folks' lives that make it really hard for them to get into the care models that we have built, which often require, phone calls and transportation and appropriate timing and that kind of thing. And then kind of thinking, a little bit further about these three particular populations that I just outlined. And again, there's a lot of overlap between these three, but these are highly stigmatized identities in our society. And, if we think about sort of, what that means in terms of how people interact with care systems, that has really profound effects. Thinking sort of in terms of racial minorities, have had a lot of historically unfair treatment by the medical system, leading to understandable mistrust, oftentimes lower socioeconomic status, and just probably more competing priorities to meet basic needs that might prevent them from engaging in care. Thinking about folks with carceral involvement, again, a lot of negative experiences with healthcare, probably prior to incarceration and particularly during incarceration. And then sort of triaging all of the basic needs and stressors that they face during that really tenuous reentry period. And folks who are living unhoused, again, a lot of people have had, sorry, you know what? I think this is incorrect. We have a duplicate here, but the specific, issues for folks who are unhoused, again, a lot of competing priorities for, just meeting their basic needs in a single day. So oftentimes making it to some sort of medical appointment or care for their OUD, just, it doesn't percolate to the top of their basic needs for the day. Additionally, I think, what all of these experiences in society really mean is that these folks tend to bring, again, an experience of stigma in so many elements of society that comes with them if we're seeing them in care settings. A tremendous amount of trauma, and whether that is from the medical system, other systems, or elsewhere in society, childhood trauma. And then a lot of mistrust of healthcare providers in general, of social service providers. So really keeping this in mind as we think about reasons that people don't engage in care and how can we help bridge that gap for them. And I would argue that a lot of times our systems aren't really well designed at this point to engage the people who need it the most. And this is just my own little hand-drawn scratchy arrows, but this is sort of how I think about, folks with any chronic disease and substance use disorder being one of those. I think there's the population of folks on the left who sort of, if we think about something like diabetes, they get their new diagnosis, they're really motivated to make changes. They have employment, they have financial means, they have social support. So they start going to the gym, they change their diet, they access healthy food, they show up to their appointments. And we see kind of a pretty, linear trajectory of improvement in their glucose control, and they do pretty well pretty quickly. that type of person, fits really well into our typical care models, right? They can make it to an appointment on time, that sort of thing. However, I would argue that probably there are plenty of people with diabetes or other chronic illnesses that take this more meandering path. And I think a lot of folks with substance use disorder, of course, do as well, right? So if we take our diabetes example, we have somebody who, they get their new diagnosis, they maybe don't have access to healthy food, they don't have transportation, so maybe they miss an appointment, they can't really change their diet. They are, in an hourly job and they can't take time off of work to manage their health, so they don't come back for an appointment for a while. Eventually they show back up, their sugars are worse. We see a little more of a winding course. And I think if we think about our sort of, most stigmatized, most vulnerable populations in terms of people with OUD that I outlined, a lot more of them are going to be on this winding path simply because of all the competing demands and mistrust and stigma that they bring into our care settings. Another way to think about this is I was just kind of the other day when a patient missed an appointment, just thinking to myself the number of steps that were required actually for them to come see me in my clinic. And I like to consider our clinic fairly low barrier and fairly accessible, but still, I think about these steps. First of all, somebody needs to have access to a phone. They need to know to call to an appointment. As we all know, going through a phone tree for any medical system is painful, and most of the time we want to hang up the phone. They can actually successfully make an appointment. They need to find transportation to come. That often might mean relying on public transportation or a friend who might cancel at the last minute. They have to arrive to a clinic or some kind of clinical setting, and they have to get there more or less on time to make it to their appointment. Then they have to navigate the lobby and the front desk, which often means a whole lot of paperwork. They need their Medicaid card, their insurance card, their ID to provide a lot of information. And then there's a giant stack of forms we often have people fill out, which can feel onerous, stigmatizing, scary, and just overwhelming for people. And then if they make it that far, then they, meet someone like me in the exam room who, as nice as I hope I am, I'm still a medical professional, and that can be really intimidating for people, particularly if they've had negative experiences in the past. So it's a really tall order to, hope that people can make it through all of these steps to get to us, to get our MOUD. So, of course, given all of the things we've gone over, not surprisingly, a lot of people who use drugs report that they have needed healthcare in the past 12 months, but they didn't seek it. And actually kind of the top reasons are sort of about, judgment and mistrust of medical providers. So I think, there are steps that we can take to help mitigate that. This is just this was a small survey that someone did in a residential setting with people with substance use disorder. And just kind of asked to describe their experiences with medical care, using a word. And you can see kind of from this word cloud that, top experiences really were stigmatizing, disrespectful, upsetting, demeaning, and uncomfortable. So this, of course, like for me as a healthcare provider, it feels demoralizing, but I hope that we can also, find it motivating that there's a lot of room for us to make changes in how people experience this. And so, often I'd like to think to myself, why have we set up systems of care the way that we have? Lots of reasons for that, but I do think a big piece of it comes down to the fact that, related to a lot of stigma, we historically haven't really treated addiction to be the chronic disease that we now are very aware that it is. And I think these quotes kind of summarize it well. This one, the profound gap between the science of addiction and current practice is a result of decades of marginalizing addiction as a social problem rather than treating it as a medical condition. Much of what passes for treatment of addiction bears little resemblance to the treatment of other health conditions. And then on the right from Dr. Vivek Murthy in 2016 said, it's time to change how we view addiction, not as a moral failing, but as a chronic illness that must be treated with skill, urgency, and compassion. So again, sort of encouraging us to think about, providing care in the same way that we would any other chronic disease. And then these are just, some quotes that I think we all hear and that are out there in the ether, sort of that highlight the stigma around substance use disorder or the lack of understanding of it as a chronic disease. So, saying that an individual should be able to stop using drugs if they just have enough willpower, or, addiction is really like a social problem and a moral failing versus a medical condition. Also the pretty pervasive attitude that somebody who is on a medication like buprenorphine or methadone is not actually in recovery. So that is all the sort of doom and gloom, but what can we do going forward? I think, one way is just sort of continue like we are, right? Have a circle and trying to put a square peg into a circle, which doesn't end up being very effective, and it's also very energy intensive for all of us. So people have been doing a lot of thinking about, how do we change our care models? So, kind of on the left is what I would argue is, our more traditional types of care models, right? You have to set up an appointment somewhere, you got to arrive exactly on time, you can't miss appointments, and you have to, sort of not have any sort of quote mistakes along the way in order to stay engaged in care. Over the past 5 to 10 years, there's been a lot more conversation about sort of, what we consider like a low barrier or a low threshold model of care. And to me, this is sort of the opening the gates, like just making it a lot easier for people to walk through the door. So we'll go over some of those principles. And then the other place that I think we're trying to move and where I'm hoping to talk about is really, beyond just opening the door and lowering the barriers, how do we truly like magnetize people into our care, right? And make them want to come and make them prioritize it because it makes enough impact for them. A number of different, important health organizations around the world have started to talk about this in the past several years, really about how treatment should be delivered. And the WHO specifically says, treatment should be available, accessible, attractive, and appropriate. And so really to me, like where we're going to dive in is that accessibility, kind of lowering the barriers, but also that attractiveness and making it like that magnet that wants to pull people in. Also, the Agency for Healthcare Research and Quality just not long ago put out an entire publication about the role of low threshold treatment for patients with OUD in primary care. And I'll be referring to some of those concepts as we go along. Additionally, ASAM, the American Society for Addiction Medicine, this is actually a draft version that was put out for public comment, and we're still waiting for the finalized version. But specifically set out, these particularly these recommendations about how to engage folks who are not abstinent into care, and that does not necessarily equate to the populations we're talking about, but oftentimes may be part of that kind of meandering course of folks' recovery. So again, the finalized version of this should come out later this year. So all of these different organizations are really recognizing that we have this life-saving treatment and we still are not able to get it to everybody who needs it. And so what are some ways that we can alter how we provide that care? So we'll talk a little bit more first about sort of the principles of low barrier and low threshold care, which have really sort of just been around in the last 5 or 10 years in the conversation. We'll talk kind of first about systems elements and then specifically clinical elements. And this does mostly come from that AHRQ document as well, which is in the references if you want to look at it later. So first, from a systems perspective, we want to be thinking about how do we make this medication available again, and I'm mostly referring to buprenorphine or naltrexone, given that methadone is still required to be administered in opioid treatment programs. So from a systems standpoint, how do we make sure that this is available in the settings that best meet the patient needs, less so do they meet the needs of the healthcare system? So thinking about how do we co-locate services, right? Where can people get kind of one-stop shopping, multiple different things that they need in one place? So in primary care settings, in emergency room settings, within syringe services programs, right, where people may already be accessing some of their basic needs and some of the other support for their ongoing substance use. Additionally, making sure that any location is accessible via public transportation. So important, right, given all of those transportation barriers that so many of our patients face. Additionally, offering telehealth services whenever possible. Since COVID, there's been a lot of data coming out that suggests that telehealth may even improve retention and care, and that patient satisfaction scores are often higher with telehealth than when in person. Services, and many folks saying that they wouldn't be able to access care at all without the availability of telehealth. So making sure that that is a piece of the care model as well. Additionally, same-day appointment and medication access being really, really vital. So again, if at all possible, whether it's a walk-in clinic or if somebody has to call, but to get an appointment on that exact same day. And there's a nice study that showed that when medication was started on the exact same day that someone presented to care, they were 7 times more likely to actually like make it in, versus if they had to wait for the next day, they were much less likely to actually make it to the appointment and get started on medication. So just really important to have it on demand as much as possible. Thirdly, from a systems standpoint, being able to provide or offer links to behavioral health services, but absolutely not requiring them. For a long time, in order to prescribe buprenorphine, oftentimes insurances to, get your prescription covered, you had to write the counseling plan. This previously was seen as absolutely foundational to being on buprenorphine treatment. However, at this point, we now know that buprenorphine alone, regardless of behavioral therapy supports, is an effective treatment. So you do not have to have counseling available in your clinic. Your patient does not have to choose to engage in it in order to be on medications. And in fact, the FDA and SAMHSA just 2 years ago wrote a joint letter, saying really specifically that MOUD should absolutely not be contingent upon engagement in counseling. So again, nice to offer links to folks, and oftentimes what we'll find is people's, their physiology stabilizes once they're on a medication. They have a little more brain space and a little more bandwidth to think about some of the behavioral health supports that they might want. And then people will often come around to asking for that care a little bit further into their medication treatment. Then moving sort of into the clinical realm, which, for some of us is more in our realm of control than perhaps the systems elements. So flexibility with the medication, and again, this is speaking about buprenorphine specifically, providing patients the option to either have tabs or films. Some people prefer one or the other based on taste or how quickly they absorb. Trying to offer the injectable form, which can either be Sublocade or Brixadi. Allowing people to have control over their dosing. So buprenorphine was FDA approved as a 24-hour acting medication. It is technically, pharmacologically speaking, 24-hour acting. However, we know anecdotally from tremendous amounts of experience with patients that most people prefer BID, maybe TID dosing. And even if someone has chronic pain, QID dosing is going to be more effective for them. And so allowing patients to figure out what works for them is a nice way to sort of empower them and provide them education about that medication and let them use it the way they feel like is most effective for them. Using evidence-based dosing. Initially, 10 years ago, when I was trained, maximum dose was 16 milligrams in a day. We now know as fentanyl has percolated in the system, tolerance is tremendously increased. And so many folks may need 24 milligrams and actually up to even 32 milligrams. And there are some references later that share more about evidence around dosing, showing that higher retention in care when people go up to 32 milligrams when needed. And just of note from Michigan, if you are a prescriber here, up until very recently, Medicaid would not cover doses higher than 24 milligrams. But as of in the last few weeks, that really seems to have changed, and they have gotten it through multiple times. So if someone seems like they are continuing to have cravings and ongoing use at a lower dose, consider increasing the dose. Having different availability of self-guided initiation. So again, not forcing people to be in the office, going through withdrawal, doing this initiation, but doing it in whatever setting is most comfortable or available to them. And then having different initiation strategies. And Open does have some of these different strategies linked on the website. But having forms, the traditional form is where somebody had to go through withdrawal for a certain period of time and then get started in their buprenorphine. But we've now developed some other forms, such as the low dose initiation, that shouldn't require that withdrawal. So this allows folks to potentially get started in a more comfortable way, and also just, again, providing options for people. Additionally, we can provide medication without any time limit on it or any tapering requirements. Again, historically, there were, I think before I moved to Michigan, I tried, there was something that you maybe needed to write, like what the taper plan was when you were starting somebody on medication. At this point, we know that really if people stay on medication, that is their safest option. And that people who discontinue, again, in large studies do tend to have returns to use. So, really continuing medication as long as it is providing clinical benefit to the patient. And certainly if you are going to taper or discontinue, it should really be, primarily based on patient desire and shared decision making between the two of you, but no requirement to do so. Again, medication continuation should really be based on sort of the clinical improvement overall, and specifically there shouldn't be any exclusion for illicit substance use, right? So if you are seeing clinical benefit, and that does not have to be abstinence, it could be, someone is still using fentanyl, but they're only using once a week instead of 4 times a day, and they're using more safely and in a controlled fashion. That is absolutely basis for continuing the medication. Polysubstance use, as we all know, is tremendously common and really is the rule at this point, not the exception. And remembering that buprenorphine only treats opioid use disorder, unfortunately, right? We wish we had medications for the other substances, but not expecting that other substance use is going to melt away just because somebody starts on buprenorphine. And I will actually say anecdotally, again, I think I often see that as someone gets started on buprenorphine and they reduce their opioid use, sometimes other polysubstance use will increase for a while, right? As people are just adapting to not having that primary substance that they were so reliant upon. And so sometimes that other use will peak for a while before people then oftentimes want to taper it off. So just remembering that, again, we're not treating the other substances. We can, of course, if someone's having any ongoing substance use, provide them harm reduction counseling and resources, as much as you feel comfortable in the office, or connecting them to somewhere that can do that with them. Also, specifically benzodiazepines, prescribed or non-prescribed, are not a contraindication to buprenorphine. There is absolutely a potential interaction. So very high dose benzodiazepines, particularly injected, have been associated with death when combined with buprenorphine. However, fairly low doses are probably not going to cause a problem. If someone is using benzodiazepines, this is 100% a time to do education and shared decision making and make sure that someone understands that risk. But it doesn't mean that you cannot prescribe buprenorphine. And the FDA came out with a pretty clear statement on that about 6 years ago, that you should not be discontinuing buprenorphine just because of benzodiazepine use, but definitely something to ask about and something to counsel patients about. So those are some basic tenets of sort of how do we lower our barriers? How do we lower our thresholds to care for people with opioid use disorder? But then I sort of, again, want to take that next step, because we have been embracing a lot of those principles over the last 5 to 10 years, and still we're missing a lot of folks. So, how do we then make it attractive enough that they want to prioritize coming into our care settings and getting started on medication? This is, again, kind of looping back to that survey that was done with folks with SUD in a residential setting. And, they were asked, after sort of being asked what was their experience in medical care, they were asked, what do you want in your medical care, in your SUD care? And not surprisingly, right, top things that came up, people wanted compassion, they wanted to feel comfortable, they wanted to feel supported, they wanted to feel empowered, validated. So again, these are things that we can build our care models to better encourage. And what I would argue is this all really comes down to relationship, right? And so again, this is something that even if we can't change our systems, right, if we are any kind of clinician and having interfaces with patients, we can work on building this relationship with people. I just think this is a lovely quote. This is from Barbara Lodge, who had a son who died of substance use disorder. And she said, "It's long past time we recognize the meaningful role that we play in one another's lives. The scientifically proven positive influence of kindness, inclusion, and compassion versus the negative effects of stigma, rejection, and isolation cannot be ignored." Or many folks may be familiar with Johan Hari, who has kind of one of the top TED Talks about addiction. And he says, the opposite of connection is not sobriety. The opposite of addiction is not sobriety. It is human connection. And so this is really a thing where I think if, can be part of our focus of our care models, as much as it's not, from a medical provider standpoint, it's not what I was trained in medical school. but it is, really foundational, I think, to, being that magnet that will bring people into care. And, these are just a couple frameworks that I think are helpful for considering specifically with the populations that we're discussing, with the histories of trauma and stigma and mistrust. Using the frameworks of trauma-informed care and harm reduction can be really helpful in how we engage people and build that relationship. So again, folks are probably aware of trauma-informed care, but I think this is just a nice summary. It's really that framework of thinking about, if someone has a certain behavior in a clinical setting, it's instead of being like, what's wrong with you? Why are you behaving in that way? It's really asking, what has happened to you that has led to that behavior? Or instead of saying, again, what's your problem? It's, what has affected you over time? And looking at really someone's strengths and trying to understand where they're coming from and how that manifests versus sort of blaming or judging them for the way that they show up. And then the harm reduction stance, again, out there in the world, much more commonly now, but the foundations, of course, are really respect, dignity, compassion, autonomy, understanding that folks have many different goals around their substance use. Some want to completely stop using their substances, some just want to use more safely. And that all of those are acceptable goals, and really, aligning our care with the goals that people have for themselves versus the goals that we may have for them. Lots and lots of harm reduction resources out there. And it can mean, everything from talking about the specifics of how to keep somebody safe while they're using, but again, really just embracing that philosophy, and patients can, feel that, and it helps them to feel more comfortable and more accepted in their care settings. So a couple of places where I think, can really build this relationship or harm this relationship, your initial visit with somebody and taking a history. So first of all, like being just overly welcoming and expressing how glad you are that they actually have made it, and recognizing, again, going back to all those steps that it took for them to get to you, recognizing that you understand that, and that you're so glad they made it. Again, looking at our sort of trauma-informed care principles, making sure that somebody feels physically comfortable and making sure they have access to the door, that we're sitting eye level with them, asking them permission to ask questions. So of course, as physicians, we are heavily, heavily trained to just fire away with our questions, but really asking a patient, is it okay if I ask you some more about this particular thing? So that, again, they feel empowered if there's something they're not comfortable with, that they can actually say, no, I don't feel like answering that question right now. Also really helpful to explain to somebody why you're asking the questions you are, right? A lot of the things that we ask around an SUD history can feel really invasive. And people have been in settings before where when they answer those questions, right, they go to jail or they lose their children. So explaining sort of the important reasons for how this is going to help you help them with your care. If you are documenting in a medical record while you're talking to them, share what you're documenting or why you're documenting it. Again, a lot of times people are going to think that this is going to go to their parole officer or that kind of thing. So letting them know that. And then encouraging them to ask as many questions as they need, to interrupt you if needed, asking them their concerns and their goals. Again, this is something that when we get rushed, and I'll speak for myself, when I get rushed, I forget, or I just don't get around to asking people their goals. And that is probably the most important part of the visit. And then, clearly expressing a harm reduction philosophy to people, making sure that they know that you align with those, with those tenets. And then using, clear person first language. And I have a chart on the next page. And then relatedly, just again, avoiding stigmatizing language as much as possible. If somebody really doesn't seem like they're ready to share certain information, avoid pressing for that unless you think it's absolutely medically necessary for what you're doing. Again, with folks with a lot of criminal legal involvement, it's okay to learn about the impact of their incarceration on their health and their well-being, but really avoid asking for details about someone's criminal charges is also really important. And then just even, before you start the visit, just sort of recenter on, I picture that Venn diagram, but whatever, visual helps you of just remembering all the experiences that most of these patients have brought into the visit with them, and that, they operate in the world as a heavily stigmatized person, and how that feels for them. This is just kind of a language chart, which again, many of these out there at this point. So, but most importantly is just again, kind of centering around that person first language, even though it's often longer to type and longer to say than the terms on the left. The other big area I wanted to highlight where we can really, I think, make or break relationship and either engage or not engage people is around drug testing. So we all know people have had many really challenging experiences around drug testing, large ramifications, right? Going to jail, losing their children. So drug testing can feel really, really heavy for people. There's a lot of debate about whether to test, how much to test. There is not excellent data anywhere that that testing is really necessarily helpful. And in a lot of countries, there isn't routine testing the way that there is in the US. So as you're making your decisions or your systems are making their decisions, again, just kind of thinking about the pros and cons. So, reasons to test. There are definitely some patients who find that structure and that accountability really helpful, right? It's really satisfying to them to come in and say that they only have buprenorphine in their urine and nothing else. So if somebody wants it, by all means, offer it. It can, in the world of our increasingly contaminated drug supply, it can really offer information to the patient about what they may be using. And I do find increasingly that people are surprised by what is showing up in there. So that can be helpful. Again, there are in systems wise, there are certainly requirements somewhere, it's not mandated by Medicaid or anything legal in that way, but certainly some systems will require it. And then again, it's just sort of in a lot of places, it's still considered standard of care, although again, this is being debated. And I just encourage you to think through it for yourself and your own setting. Reasons to consider not testing or how you're testing. Again, there isn't great data that shows that there's impact on any kind of meaningful outcome like reducing overdose or encouraging retention. Patients absolutely report that it is stigmatizing, it's traumatizing, it's anxiety provoking. Some will say it makes them, avoid coming to care. There are many false positives and sometimes false negative results on our point of care testing. So we're sometimes making big decisions around things that are not really objective or accurate. And then thinking about those really far-reaching implications, right? Even if a positive test isn't going to mean anything in their medical care, if they have released records to their parole officer or, their CPS worker or something related to their employment, these have enormous ramifications for people in the rest of their life. And so remembering that when you're weighing the risks and benefits of testing. Also, sometimes clinical logistics are complicated for getting testing done, particularly like doing it in a way that is sensitive to patients' experience. So that's another consideration. If you do choose to test, just some considerations here again to maintain that relationship, consider again what that impact is going to be for the patient, both clinically, is this going to change what you do in any way or your counseling of the patient, and what will this mean for any other elements of their life if it goes beyond the clinical setting. Remembering that it is traumatic for people to test and think about is this going to give me enough important information that it's worth, making patients feel re-traumatized by doing it. If you are going to do it, be, just really clear upfront with patients about how often you ask for them, how you're going to use the results, that kind of thing, so that they, have a clear map and understanding. And, this is just sort of my own thought. And again, there's no good data around this, but if you are going to ask for urine drug testing, I would recommend sort of just doing it routinely instead of on a sort of as needed basis. That sort of as needed basis requesting is really subject to our implicit bias and stigma that we may carry, right? And a patient may feel extra stigmatized if they're not asked for it sometimes, and then occasionally they're asked for it, wonder do I look like I'm high? Is there something about my identity that's making it so I have to leave this sample? Remember that many tests are really inaccurate. So always clinically correlate. Does this actually match up with patient history? And then, ideally asking for patient consent before running the test and sharing the results with them. And just if you are going to test, really important things, just to, don't let this, any result harm your relationship with the patient, right? That is of utmost importance, is maintaining that relationship. and don't make one clinical decision based on a single testing result. Again, given all of those false positives and false negatives. To not require observed samples. Again, there's no evidence behind doing this, and they are phenomenally stigmatizing and traumatizing for patients. Also hard in most settings for the staffing to do that. And don't assume that tests are accurate necessarily. So apart from all those things that we can do ourselves to really maintain this relationship and, pull people into care, I think very much what I consider sort of the secret sauce of that, the most supportive and engaging care that we can provide is centering people with lived or living experience, right? And this can be this in the form of having a peer support or a peer counselor in your clinic, right? And at this point, if somebody is trained as a community health worker in Michigan, that can be billed. So there are more opportunities to have those folks directly and engaging with patients and engaging with us as the providers, right? And I think, for me, working with peers over time has given me a tremendous amount of education that I certainly did not get in my medical training. And also they are just able to much more rapidly build trust with patients because of that shared experience. So they can be sort of your magical, trust tool as a medical provider, and help bridge that. So can't advocate for that enough. You can also have, consumer advisory boards are definitely increasingly being used, right? And having a meaningful way of engaging people to make some of those decisions about how care is delivered, people who actually have that experience. And then similarly, a sort of, service co-design, and this is, again, like as a care model is being developed or as it's being revamped, having very meaningful contributions, sort of not just, superficially having people with lived experience give input, but truly giving weight to their input as much as to the other professionals who are involved in that design, can also really, really help to set up these highly engaging experiences for our patients that will draw them into care with us. So I know I've gone over a whole lot of things, and I know to me, it all sounds great, but there are a lot of challenges to implementing what I've just gone over. And I will be the first to say that in my clinical setting, we have not implemented all of these things by any stretch of the imagination. And we still have a long way to go. Some of the barriers that we hear from folks about this over time is, okay, first of all, staff still feels really stigmatizing to people with SUDs. So even if I change what I'm doing in the clinic, like patients are still having this really difficult experience with the rest of the staff. Certainly time, always the number one challenge, right? Like, yeah, I want to build a relationship. I want to spend time with patients, but I've got a 15-minute visit and I have to cover 3 things. Policies, certainly different institutions and systems have tons of policies, and a lot of them may not be evidence-based. Some people are operating in locations that require abstinence to continue buprenorphine. Some systems do require behavioral health involvement in order to prescribe buprenorphine. There's also the comfort level, right? I think a lot of us, I myself included, were trained that buprenorphine might not be safe if someone is using other substances, particularly sedatives. So it can just sort of be, provider level of comfort and feeling nervous about the safety. There's also the lack of resources, right? I went over the amazing element of having a peer support available, but that is not always, there may not be resources or institutional will to support that. Likewise with, other case management or social work services. So lots of reasons this stuff can be hard to implement. So we'll not pretend that those don't exist. That being said, I think even if you are in this larger system that has a lot of challenges to it, there are still hopefully nuggets I think you can take away, and I hope that you can take away. And specifically what I think are sort of the low-hanging fruit. You as an individual, whether you work at the front desk, whether you're a provider, you're a social worker, you can individually with that patient build a strong relationship with them. You can build trust and you can make connection happen, regardless of what is happening around you. You can advocate to change policy, of course, within your systems, and you can certainly use references for this presentation, or if you wanted help, you contact Open, and we're happy to talk through strategies about that. You can educate your staff, right? And this doesn't have to be a whole presentation to your staff. This can be really quick and informal. It can be sharing a story about a patient. If you hear a staff member using, language that isn't person first, you could just, let them kindly know that there might be a kinder way for them to say that. And oftentimes, right, again, a lot of the staff around us they may see how a patient is showing up in clinic. And again, because of everything they're bringing with them, they may be, sort of quote, misbehaving out in the lobby, right? But then being able to generally share back stories of how patients get better or how they've had histories of trauma, those things can really help for staff that, are not necessarily able to be in the room and understand more of what might be behind that behavior. Again, person first language, using it with patients, using it with your team members, using it with all of the staff. You can always do quick counseling around harm reduction strategies. And again, there are a lot of resources out there for really quick things that you can do in a clinical visit. And then you can contact Open anytime. Again, like you could do a clinician to clinician consult if you're uncomfortable, a patient's on a benzodiazepine and you want to give them buprenorphine and you want to talk it over with someone. We also can provide, specific educational sessions for different institutions if that is ever helpful. So please do reach out to us as much as you can if you need us. So I just encourage you to pause for the moment. And since this is not the most interactive, I won't ask anyone to share, but just do think about like what is one step that you could take even this week, whether that is just changing one word that you use, whether that is talking to an administrator, what is one thing that you can do to open the gate, lower the barriers a bit more, and then try to make that care a little bit more magnetizing for the people who need it the most. And I'll just end on this slide of, just quotes from patients over time that I think reflect the power of this sort of care. Somebody said, wow, I just told you a whole bunch of things I've never said out loud. I've never been somewhere I can say things so honestly. Somebody else said, I get a smile on my face every time I walk in here, which is not, I think, that common in a medical clinic. I don't feel that way when I go to a medical clinic. Somebody else said, I love coming here. I know you guys really care about me. I've never been somewhere that calls me a million times if I miss an appointment. And then someone else said, I want to thank you guys for all you do. I don't know where I'd be without you. Felt myself slipping backward and felt like no one cared about me. I'm really glad I have you guys to help me with everything. So thank you so much for listening. I'll just leave that slide up because that's more interesting than the references, but we certainly can share out references as well. And I appreciate you all joining. I am going to turn over to Melissa in case there are things in the Q&A. And then, we're happy. I think we have a couple of moments and happy to answer any questions or hear anybody's experiences via the Q&A.
Thank you so much, Liza. This is such valuable and helpful information. If you could direct your attention to the chat, you can see our link here for the survey to complete to get continuing medical education credits, social work CEUs, and McBAP credits. Any questions for Liza, please submit them into the Q&A function.
Liza, I have a question for you.
Yeah.
For people who are want to incorporate peers into their work, but maybe don't have the resources to hire somebody directly in their clinic, are there other places that they could look to connect with to still be able to help patients find that support? Because I agree, it is so important.
Yeah. Great question. So one great way is connecting with syringe service programs in the state. They almost always have a lot of folks with lived experience available, and whether they have had the official peer certification training or not, they have a lot of folks with lived experience available. So actually back in my Seattle clinic for a while, we didn't have our own peers, but we worked really closely with an SSP who was able to provide some of that care. So that, partnering with other organizations can be a really great way to do that. Yeah,
Thank you.
Great question. It is hard. And there's currently, if someone doesn't have a community health worker training, there's no way to bill for that. So another way around that, again, if there's institutional will, is to hire somebody with lived experience to get them trained as a CHW, and then they can actually bill for services, which is fairly new in Michigan in the last year.
Okay, I didn't realize that.
Which is great that that's starting to be covered more.
Awesome, thank you.
I have a quick question too, Liza. You mentioned same-day appointments with medication. If the person has to go to an outside pharmacy, is there a way to coordinate that for them? If you're not an FQHC, you don't have a pharmacy in-house?
Yeah, so I mean, typically, if you know, and maybe in really rural areas, this might be harder, but typically pharmacies do stock it, stock buprenorphine. So it should be available the same day, usually, you know, within an hour or two of when you prescribe it. And I will say there's there have been letters from the DEA and from a lot of different governing bodies, you know, encouraging pharmacies to have it more available because there have been, you know, issues of it not being stocked. But there's a lot of advocacy on the pharmacy front to make sure that it's more available on the day that people need it without delay. So hopefully that is alleviating some of that challenge. But yes, in a dream world, there's an in-house pharmacy, but otherwise, local pharmacies should have it. And if you can, like as a, you know, whatever your system is, have a, you know, relationship with a couple of pharmacies in your area that you know feel like are sort of on board and don't stigmatize patients too much, that can be really helpful too, and you can get to know the pharmacists in the area.
Thank you.
Great.
Thank you. It is 1 o'clock, so I just want to thank you again, Eliza, and thank you everyone who joined us today, and I wish you a good day.
Great. Thanks, everybody.
Bye.
Bye-bye.